All right, so it's recording on my cloud, and I'm going to share my screen, the desktop here. Great. All right. So, hi everybody. My name is Tara Khan. I am president of the Pennsylvania State Nurses Association. I am honored to be speaking at the PASNAP Virtual Hall of Delegates, and also want to give a shout out to Lydia Robbins, an amazing community organizer, also a friend I've worked with before, for helping out with the content. So why advocate? As nurses, we bring a unique perspective on healthcare issues. Even if there's any students on this Zoom, our perspectives are really important. We have unparalleled access to patients. We have an awareness of issues that legislators do not have. We are experts on issues that our patients are dealing with because we have that one-on-one access to the patients. We are on the front lines. We see things. Even during the pandemic, I've been talking a lot about the work that I've done on the pandemic, and I've continued to make this point that if legislators had only talked to nurses, if policymakers, if health departments had only talked to nurses, this pandemic would have been much better managed because nurses know what is going on. We know the issues, and many times we know it before the rest of the country knows. Also, I love advocacy. It's so much fun to go to the Capitol, to talk to a legislator about issues, especially when you're there in person. This is going to get more fun as this opens up. And as you know, we are the most trusted profession. Nurses are seen as heroes, and our patient stories are really gold. One thing that I do as an advocate and activist is that I will often, on my notes section, write down patient stories without any PHI. I'll just write down what happened, especially regarding issues like when the Affordable Care Act was under threat of being repealed. I very often would talk to patients about their access to healthcare and the fact that if not for Medicaid, they would not be able to afford certain things, or maybe they just got a huge bill, but because of the Affordable Care Act expansion of Medicaid, they were able to pay for their medication. So keeping those stories and sharing them with legislators are so important. When they are talking about bills, it's those stories that actually they think about. So especially when we talk about the safe staffing, collecting those stories, even it may not happen on this call, some of these stories, because we're going to talk a little bit about that, but you may think of it later, and make sure you write those down, those stories because they're really going to resonate with legislators. And then, COVID-19 shows us, as I mentioned, that it really is because of nurses that we were able to start to get what we needed for our healthcare workers: the PPE, the testing, access to vaccinations, doing a lot of advocacy myself around vaccinations as well. And especially when we're looking about addressing the social determinants of health, health disparities, disability, racial inequities, that's something that nurses are uniquely qualified to lead on. Also talk a little bit about the duty of being a nurse and being in the position to advocate for. When we took our Nightingale Pledge and we said that I solemnly pledge to devote myself to the welfare of the patients committed to my care, that is part of it, advocacy outside of the bedside. So in the legislative sphere, in the community sphere, in the union sphere, when we're advocating for issues, we are advocating for the welfare of our patients, and that is part of our Nightingale Pledge. The World Health Organization has called on health professionals with our expert knowledge and our influence with politicians and the general public to be that force in mobilizing support and initiating change. And Ted Kennedy, when he gave his famous 1980 speech at the DNC, he talked about the glory and the greatness of our tradition in the U.S. to speak for those who have no voice, and that is very much aligned with nursing values. There's values to be that advocate for those who have no voice. When we look at history, nurses have really been at the forefront of advocacy. Margaret Sanger, founder of Planned Parenthood, going around the circle here. My advisor, Dr. Mary Naylor, who I know is Patty Eakin, her teacher actually, back at Jefferson back in the 70s, spoke. I remember when the ACA was being passed, Dr. Naylor actually spoke in front of that Senate subcommittee, talking about the need for transitional care. And it was actually because of Dr. Naylor that was implemented in the Affordable Care Act. So the amazing power that nurses can have to make policy. This is Eddie Bernice Johnson, who actually, I believe, her serving her last term in Congress, the first nurse to serve in Congress. And as we go around, we see our state rep, Maria Collette, who of course was a nurse and is one of the prime sponsors on our Patient Safety Act. Erin Murphy, who actually was the Speaker of the House in Minnesota, ran for governor unsuccessfully, but now is back in the state Senate in Minnesota. And of course, Cori Bush, amazing advocate as a congressperson. And it's actually because of Cori Bush that we had a nurse put on the COVID advisory committee for President Biden and Kamala Harris. It was because of Cori Bush that we got a nurse on that, something that we've been advocating for, but it took a nurse in a leadership position to get that done, which really speaks to the need to get more nurses in leadership positions. And of course, my favorite nursing activist, Harriet Tubman, who was a nurse during the Civil War, one of the greatest Americans I think that we've ever had, was a nurse, and an incredibly point of pride that Harriet Tubman was a nurse. So how does a bill become a law? This is my next slide kind of goes into it. But is anyone on the call, able to, in 35 to 45 seconds, able to kind of just talk about how a bill goes from being a actual text to becoming law? Which is okay, because I'm going to go right to the next slide. And this is courtesy of Nurses of PA. Actually, this is a former staffing bill. And it talks basically, it kind of lays out how, a bill could be introduced in the House or the Senate, or it could be introduced at the same time. And it goes from being introduced to right into a committee. And depending on where it is assigned, sometimes that determines whether the bill moves. Sometimes the bill can be assigned to a committee, and whoever is the chairperson of that committee decides that they don't want it to move. And so it starts in a committee, so possibly the House Health Committee, or if it's in the Senate, the Health, Human Services Committee. We would hope that they would actually take that up for discussion. And before voting on a bill, committees can hold a hearing to discuss, refer it to a subcommittee. And then when ready for a vote, the committees can table it, amend it, defeat it, or accept it. So we actually hope that it actually comes up for a vote. Again, sometimes it doesn't. It then goes to, if it's in the House, to the House floor, or if it's in the Senate, to the Senate floor. And basically, I think that the purpose of this exercise here is just to know that they can add amendments and actually change the bill. Sometimes can change the bill entirely. So that is another kind of wild card. And then we hope that the House or the Senate would then vote for the bill. And if they pass it, it then goes to the other chamber for that whole process to kind of go over. So basically, once a bill is passed by both chambers, it then goes to the governor to be signed or vetoed. And when we talk about the Patient Safety Act, we do know that that Governor Wolf is likely to sign it if we can get it to his desk. All right, so talking about the reason why we're here, the Patient Safety Act, a little bit of context. The International Council on Nursing actually recently called on nurses to act on safe staffing, nursing agencies across the country, because of the consistent, clear, persuasive evidence that interventions like minimum nursing safe staffing levels are associated with improved nursing and patient outcomes. The evidence is overwhelming. Lower hospital nurse to patient ratios are associated with less patient mortality, less falls and adverse outcomes, shorter hospital stays, improved patient satisfaction, fewer healthcare related infections, less ICU admissions, and fewer readmissions back to the hospital. And we know from research that there's not a shortage of nurses, there's just a shortage of nurses at the bedside because of unsafe staffing conditions. Now, before the pandemic, we know there was understaffing well before that due to cost cutting, increased disease complexity, and an aging patient population. Prior to COVID, chronic understaffing resulted in nurses who faced dangerous physical and mental stresses, longer shifts, exhaustion, burnout, all which led to increased risk for medical error. 70% of patients, 70% of nurses in Pennsylvania that were surveyed, they confirmed that inadequate staffing negatively impacts their ability to serve their patients on a daily or weekly status. Now, there's been different studies. PASNAP recently published a study in a pamphlet on safe staffing, and it confirms about the same time, about the same numbers approximately. No matter who is doing this this research, we find it. Nurses are saying that on a daily or weekly basis, unsafe staffing affects their role, and that is whether they're at a magnet hospital, whether they're at a a small community hospital that's not magnet, or large for-profit. They're saying the same things. In the US, also, medical errors are the third leading cause of death. I mean, think about that. The third leading cause of death is medical errors. That is just absolutely intolerable. We learned about, I think it was in February, that a study that was published by University of Pennsylvania by Linda Aiken and her team showed that each additional patient added to a nurse's workload is associated with a 13% higher mortality in hospital, and also an 8% higher readmissions. 13% in hospital mortality. I mean, that is astounding. Also, the odds of staying a day longer in the hospital, which is a major cost factor, increased by 9% for surgical patients and 5% for medical patients. These research estimated that if all New York hospitals had staffed at levels recommended on our legislation of not more than 4 patients per nurse on medical and surgical units over a 2-year period, more than 4,300 deaths would have been avoided, and over $720 million saved just among Medicare patients in New York. I mean, that is pretty astounding. So when we are hearing arguments about costs and how much it's going to cost to safely and adequately staff hospitals, we look at among Medicare patients alone in New York, that if it was staffed properly, they would have saved $720 million. It's just absolutely astounding to me. So safe staffing in Pennsylvania means decreased patient deaths, less adverse patient events. States also that showed that nurses, when they were properly staffed, that there were a decrease of injuries of nurses. So nurses are getting hurt less because they have safe staffing. And we know about nursing burnout, 30% reduction in burnout. And in Pennsylvania, there would have been 6,000 less infections in the hospitals per year if we had safe staffing. And finally, a conservative estimate would be that if Pennsylvania had safe staffing, that we would save at least $68 million a year, which would obviously play a key role in paying those extra nurses to staff units. So some principles of the Patient Safety Act, this amazing bill that we have, House Bill 106, Senate Bill 240. The principles in this bill is that nurses have a duty to protect patients. Hospital staffing should reflect patient care needs, the complexity of the care, and the services needed. There should be a mandatory adoption of uniform, minimum, numeric, and specific nurse ratios for safe care. And nurses need to be able to advocate for patients without worrying that they're going to be retaliated from their employer, and that whistleblower protections are definitely needed. So this was me and a few other amazing nurses and a couple legislators. The Patient Safety Act, this was back in February when we announced it. And this was also historic because we had PASNAP, we had Nurses of PA, we had SEIU Healthcare, and we had the Pennsylvania State Nurses Association coming together on one bill. And we had a very bipartisan, we were talking right before we opened up. Right now, there is, I think there's 30, at least on the screen that I saw, and this probably is old numbers, but at one point we had 30 co-sponsors, and 13 of them were Republican, 17 were Democrat. I mean, this is about as bipartisan as you get, almost split down the middle for being bipartisan. So the Patient Safety Act, again, House Bill 106, Senate Bill 240, Patient Safety Act. In this act, we have protection of ancillary staff. We have protection of nurses refusing assignment. We have safe staffing committee chosen by nurses. Most important, the cornerstone of this act is a flexible, safe staffing standards with a floor that cannot be lowered. So we'll talk a little bit about some of these standards, but this bill will be implemented 6 months after passage. So that gives hospitals plenty of time to start to hire up if they need to, and to take into account the provisions of the bill. So, I mean, I think it's pretty obvious, but why we need it. But I would like to know if you wouldn't mind considering for a few moments how unsafe staffing affected you, and then please raise your hand or answer in the chat of a personal story, and in like 30 seconds, an elevator pitch of why a legislator should support the Patient Safety Act.
Folks, I think also the nice thing is since we have like a good small group here, you are in a safe space to share your story. I know you. Great. Thanks, Francine.
Hi, Tara. I'm Francine Fajik, and I am a nurse at Temple University Hospital. And when I first came to the Temple Health System, I was a pediatric nurse. We had a Temple Children's Hospital. And what struck me odd, when we were short, we could have anywhere from 6 to 8 patients, pediatric patients on the floor, sick children. There is legislation for how many kids can be in a classroom. But when your child comes to the hospital, there's nothing. And I could have an infant all the way up to 18. I don't know how you would manage kids just alone, 6 to 8 kids not being sick, but 6 to 8 kids sick takes a toll. And that's why one of the reasons why I became active with safe staffing legislation way back when was because there was nothing protecting us for limits. When they're short, they don't care. Oh, well, make do. And make do, we do, but it doesn't leave us when we leave the door. We worry about it when we're sleeping. Did we make the right decision? Did we miss anything? Did something happen because of us? Did we make a med error? All of that stays with you when you're short staffed. And that takes a mental toll on you, which leads to burnout. And I have seen many of my colleagues in pediatric and adult burn out and leave because they can't take it anymore. And over this past year, it has been basically a mass exodus of retirement, people choosing to take retirement. I think COVID has amplified the short staffing issue and the toll it takes on us professionals taking care of these patients. And that's why I'll continue to be active and trying to get a bill, passed.
All right, thank you. Thank you so much for sharing that. And so basically, it's sort of your experience of working. Was there an actual one experience with a patient or with a with a child that maybe and Lydia, let me confirm, we are recording this, right? Who else would have access to this? Just want to make that clear.
Yeah.
Yeah.
This is about having access for people who wanted to attend the training, who
Okay.
are already signed up for the House of Delegates. It's
Okay,
not
so
a
this would just be amongst PASNAP folks. It's not going on the web or anything.
no. This
Okay,
is
okay.
if you wanted, if you were in another training and you wanted to get to this one, but you couldn't.
Yeah. Is there a was there an actual patient story that you could think of, Francine, of someone that maybe didn't have a good outcome, or a time where you felt that a child's life was at risk because of the fact there wasn't two of you because of staffing?
I can think when I first started at Temple Children's, we were short, we were on the floor, and there was a child that was admitted, my patient, newly diagnosed diabetic, needed frequent sugar checks, needed labs. And I had 6 other patients. And I, as luck will have it, I did escalate, and someone helped me out for a few hours, but they were management, so they left on time. And, I had that patient for 12 hours. I remember the physician at the time, because it was a new face, they were, on me about getting it done, thinking I didn't know what to do, when the problem was I didn't have the help of getting it done. And, it was unfortunate. The patient was fine, but it never left me, as you can see. I still remember that. And I just can't imagine in COVID what my colleagues are dealing with now, in comparison to what I dealt with that patient, how they're dealing with this on a day-to-day basis. It's the same story over and over again of how short we are.
Wow, that I can, and I could hear that in your voice too, and I really resonate. Really resonate. Thank you for sharing that. Is there anyone else that wanted to share a story about, personal story of how unsafe staffing affected you, and why we need safe staffing in Pennsylvania?
I mean, I know you guys. I'm sure from everybody here, it's a hot topic because there's been issues in the hospitals that are just not where it would have made a huge difference if you had enough staff to have assignments that were reasonable. Right?
Is there anybody here from Einstein? Because I understand that staffing is an emergingly bad issue. I mean, certainly we know it is at Temple.
Mm-hmm.
Yeah, and I think even if there's not an actual story, I think some of that sort of how Francine, you were saying about how it wasn't a matter of you not having the knowledge. It was just, and this is maybe my words now, but there wasn't two of you, there wasn't three of you to do that job. And also, I remember when I was on the floors, I feeling like I did not want to go to the bathroom because I couldn't take the time away, or I couldn't go to lunch because I didn't feel safe leaving my patients. And I think those really personal stories. So I would say just continue to think about that, because the more personal you are, those stories really stick with legislators. They really stick with legislators, especially the more specific you go. And again, keep it to a good, minute and a half max, a good elevator pitch. But those can really make a difference, because when a legislator has to deal with that story and think that, okay, well, that's just one nurse. How about all of the hundreds of thousands of other nurses in Pennsylvania having the same story? What am I going to do for patients just like that, and for nurses for that? And I think the last thing I'll say on that is that the more we can tie it to patient need and patient safety, the name of our act is the Patient Safety Act, the better that legislators really understand that. That this really comes down to the safety of our patients. The safety of nurses really is the safety of our patients. But this is, I think, really making that explicit, that this is about protecting our patients, that young child who needed blood sugars every 2 hours, but there were 6 other patients that you had to take care of at the same time. Or I'm sorry, it sounded like it was more frequently than that. And you just couldn't do it. All right. So let's move on to the next one. Whoops. So the meat of this bill really is the safe staffing standards, and we're calling them standards because that's basically what it is. I think in the handout that I saw from PASNAP, it was actually, I've said this before, really well said. It is the wild, wild west. There are no standards right now. When we think about what we need standards to keep our patients safe. I mean, you wouldn't just hang a drip without any guidelines. There is an order for what that drip needs to hang at, how many, what the rate is per minute. So these are standards to make sure that our patients are being safe. So the standards, ICU, CCU, 1 nurse to 2 patients or less. Again, these are not fixed standards. These can be adjusted. So for example, in the PACU, if 1 nurse to 2 patients is not safe, that can go down to 1 nurse to 1 patient. These are not rigid standards. These are not rigid ratios. These are flexible, but they only go one way. We're not going 1 to 5 in the PACU. We'll go to 1 to 1 if 1 to 2 is unsafe. Pediatrics. So this would actually have addressed that issue. It would actually bring peds to 1 to 3 instead of 1 to 6, which is really unmanageable. Med surg 1 to 4, ER 1 to 4, psych 1 to 4 or less, rehab SNF 1 to 5. These standards would also be reported. So every hospital you would go to, they would actually have this posted, and it would be called the rights of registered nurses as patient advocates, employees, and patients. And it would list what the contents of this bill are, so that everyone knows and it's clear. So, if you have a floor that's full of fairly new nurses that maybe aren't familiar with the bill, this will be posted. So someone will see it and say, why do we have 1 to 5 in med surg when it says 1 to 4 or less? So that is part of this bill, that reporting of it. All right, so this is a little bit of how would you respond? So take 30 seconds and reflect. And I think since we're in a small group, you can just raise your hand. So you call your office of your state rep and you ask for the support of the Patient Safety Act. The legislative director says, I spoke with the hospital association and they make a good point. What is a safe ratio? Isn't that subjective? I mean, what works for 1 nurse might not work for another. Also, patients are more than just a number. So why should hospitals see staffing in that way? So how would you take a moment to reflect, and how would you respond to that legislative director on those points? And there's also no wrong answer. Unless it's really bad, then it's wrong.
I guess it's Francine again. I guess what I would say, I wouldn't say it's subjective. A patient, it's not subjective. It's creating a standard. Other professions have standards. Air traffic controllers, how long you can be on the road as a truck driver. how many students can be in a classroom. We need standards. We have seen that patient care go out the window when we want to cut costs, and nurses are one of the ways they cut costs. So it really isn't subjective. It's basically a safety standard. And yes, one nurse could be different than the other, but our standards should be the same no matter where we go.
That's great, Francine. That's well said. Very well said.
Anyone else have something they want to add? Just based on, I mean, I know some of us would have some immense amount of frustration with the, you know, the staffer who says that, but like, what are some other thoughts that people have? Feel free to just like offer some additions.
Would it be correct to say that what you're getting there is just a hospital talking point, basically, that to say that there is, you know, it's different for every nurse, it's this, it's that. These are just dancing around, you know, what Francine just said, which is that at the end of the day, I mean, it just pure logic. There's all kinds of research. Like, you know, I'm sure there are people here who know more and can quote chapter and verse from study after study that's been shown that the single best predictor of patient outcomes is nurse to patient ratio in terms of a lot of different things, right? I don't know. Is that a helpful way of framing it for them?
Yeah, definitely. Again, there's really not. I mean, there's really not a bad way to answer this. Unless it's really bad. I mean, unless you're insulting them. But yeah, you're right. This is an absolute talking point. In fact, this is a real talk. These are all real scenarios. That is actually you know, when we came out and we announced this, it took the Hospital Association about a week, and their first response was that patients are more than just a number. That's why standards are bad. You know, it's like, what are you talking about? It is a very lame talking point, but you're right. It's them dancing around the issue. And just like Francine said, I mean, we need standards. I mean, because right now there's nothing. Anybody else want to put again? Feel free to. This is a safe space.
Has anybody ever heard this kind of line when you've tried to negotiate this? You know, in a contract setting, where a hospital might say, "Oh, we can't give you guidelines or we can't give you ratios because this is all subjective." You know, one nurse's tough assignment is another nurse's, you know, easy day. Anything like that? And how did you guys respond in bargaining if you did try?
Yeah, it's a good question.
I just thought it might be another way of framing it if thinking it's about it in terms of legislative and it is not familiar to people. Like maybe that labor management or bargaining context might be a little bit more familiar. Like how do you tackle or answer those kinds of, you know, when management's just trying to parry and, you know, basically waste your time and hope you forget about it.
Lydia, do you have any
Yep.
anything on bargaining? Yeah, I can hear you now.
Yeah, I mean, I guess I'd say here, you know, you guys, I know for me, as a union organizer, I've sat through many bargaining sessions where nurses are pushing for staffing ratios in the contract, and you know, basically you get similar responses from management? Anything other than like, of course, we'll just agree to that. Has anyone ever had a conversation around staffing ratios with their employer, be it at bargaining or just like in terms of improving staffing in their hospital?
Yeah.
Yeah. What are some of the responses that you've gotten from them?
Our manager in negotiations, she told us that she didn't know staffing was that bad.
Yeah.
That she cried at the negotiations table because she was so baffled why she didn't know why this was happening before.
Mm-hmm.
Uh-huh.
And did they agree to it?
We got some slight modifications to some staffing issues, but no grids or things like that. Nothing that we wanted. We got some extra staff. We got a resource nurse. We've got charge nurses with half assignments, but no one's following since COVID hit, like it went to shit. Like nobody's following them. So we just had a meeting and everybody's going to start filling on unsafe assignments if the charge nurse doesn't get her half assignment, because that breaks down everybody else's assignment. It helps everyone down the line.
Yeah. Yeah. Anyone else? Just anyone else? I see that there's a few other folks here. Like, what's the similar story, especially since COVID? Have you guys tried to fight for better staffing and gotten similar responses?
Well, COVID has really complicated a lot of things, because you really have no staff. They continue to be short. They continue to say, like, we have established the way in which they should. Part of our negotiation was that we went through how they should like call people in to try to get extra staff in. We have a new CNO, and she had actually went through where they had this incentive and they were getting paid more, but you were still using the same people to come in, and they were starting to get burnt out. I don't like burnt out. They were. You can't continue to utilize the same people and think that they're going to be able to work under those conditions. And they took away the incentive, right? I believe 3 weeks before it was due to be over, and people stopped coming in. So you're right back to where you started day one, and people still frustrated, and people are starting to say that we negotiated for nothing, and we're right back where we started from. So the frustrations that we had before we even got the contract are back again. So COVID's just complicated a lot of things. And we're down PCAs, and we have one where consistently they fill out short staffing forms every weekend, and it's horrible. It's horrible. So I'm glad I jumped on this so I can hear. It was enlightening to hear that Einstein is having staffing issues as well, because now I can take back and say, well, here I told somebody it was bad out there, that I'm hearing is bad everywhere. Now I can have some examples as to where they're having issues as well.
Thank you for sharing. Thank you so much for sharing that. I mean, it really, and I think this bill really solves a lot of those issues in terms of the actual staffing, but also the support staff and making sure that those are protected. One of the ways that another way you could go about this is to enumerate that the patient limits in our bill are based on studies from around the country, and they're taking into consideration feedback and evidence-based practices, and then kind of circling back and saying, can we count on you to support the Patient Safety Act? Another provision in this bill is safe harbor, which basically when nurses are feeling that they're asked to staff an unsafe assignment, they may make a good faith request to refuse the assignment. Nurses can refuse assignment that they do not have knowledge or skills to take an assignment. For example, if you're a med-surg nurse being pulled to an ICU, you can refuse that if you feel like it is unsafe for you, and there's protections in this bill. Another a thing to consider, and I see that we're running a little bit up on time, so maybe we'll just have one person in 30 seconds, if possible, about your meeting with the state rep. You ask them to support the Patient Safety Act, and they say, "I stand with nurses, but a hospital in my district just closed because they were woefully over budget. I know staffing is important, but if it bankrupts them, we're going to be down an entire hospital, and we can't afford that." What would you say to that state representative? Or how might you respond? And if you've gone already, you can go again. It's totally fine.
Also, go for it.
Well, number one, I would say that it's not the nurses that break the budget. We actually save the budget.
Yeah.
If there are more of us, based on the studies that have been conducted, not just by nurses, but by doctors as well, if we are there and there's more of us there, we're the first line of defense to prevent falls, to prevent unforeseen outcomes like dying and medication errors. We're not burned out. If it's more of us to care for our patients, then you wouldn't have as many litigations in court where people are filing malpractice for falls, that now when someone falls while they're in the hospital has to eat the cost now.
Yes.
If someone gets a pressure injury, the hospital has to eat the cost now. And if there were more of us there at the bedside, we can prevent those things from happening.
Very, very well said. I think the literature is becoming clearer and clearer that actually safe staffing saves money. And more important, though, is those injuries and lives. But those injuries and those lives will cost hospitals a lot of money. And it actually makes better sense for them just to keep patients safe in the first place. It's going to save them money. So also in this bill is more protection for nurses. So there is no mandatory overtime that hospitals can use to meet safe staffing standards. So if they need to, if they're going to be short for the evening shift, they cannot force nurses to stay just to meet those staffing standards if they can't get that. There's also $25,000 fines for violating the Patient Safety Act, and if those shifts are unsafely staffed, those fines can carry over per shift if not corrected. So that really makes it imperative for hospitals to make sure that they are taking staffing seriously, so they will not incur those fines. And believe you me, they will avoid paying these fines by making sure that these hospitals are properly staffed. There's also civil penalties for violating nurses' rights under this act, $20,000 for each instance for violating those nurses' rights. And then also nurses that are unlawfully fired for either refusing an assignment or for doing something that is protected in this. Nurses can actually recoup whatever lost wages that they are and get either severance and other provisions. There's other protections which are explained further in this bill. So just a couple more of these. How would you respond? And then we're pretty much at time. You see your state rep at Wawa or Sheetz. Apparently there's a Sheetz in Pennsylvania. I knew of Wawa, but that tells you that when you ask them about supporting the Patient Safety Act, they say nurses are heroes. But honestly, if there's anything we've learned from the pandemic, that we have to be able to adjust. And if there's a safe staffing law, what's going to happen in the next pandemic? Will the hospitals be forced to close because they can't meet the safe staffing needs due to unforeseen circumstances? So how might you respond to that?
Also, folks, I just want to say it's been a really frustrating year for people, especially on staffing. If you can do the version that is more what you would like to tell the administrator or the representative who would think that this was an okay thing to say. You can be straightforward. We're practicing.
Yeah, that's a great, because you don't always have to answer with the exact thing to the content of what they're saying, but it can be sort of the sentiment of what they're saying you can respond to. And that's really good practice too, because you don't necessarily have to throw research back at them.
Oh, we have a lot of hospital administrators in this presentation that have been hanging out with our state legislators, apparently, because they're just like zipping out the talking points here, like why we can't.
Well, I just don't want to talk all the time because I do know how to.
Yeah, go for it. Go for it.
Go, Francine.
First of all, we're not heroes. We didn't ask for this. You know, I would have to say that we're not heroes. We didn't ask for it. And everyone stepped up in this pandemic. There was a clear, I think COVID amplified, there's a clear national shortage of nurses at the bedside in the hospital. You wouldn't have the call that you had this time around, the next time around. I think on all different levels, we would be better prepared for a pandemic next time around, and our staffing would be a lot better if you start now.
Yeah.
And don't wait for later. Okay. I don't see the same thing happening. I think you would have more people get into nursing if we have safer standards and for our patients. Then you wouldn't have what you have this year, this horrible year.
Francine, you killed it. You killed it. That's exactly right. Their answer is the Patient Safety Act, because if we had the provisions, we would not be in the shortage of nurses at the bedside that we're at. It's making sure that patient safety is prioritized. So the next pandemic, we're going to be prepared, and nurses will not be stretched too thin because we will be ready for it. And then can we count on your support to make sure that we are passing the Patient Safety Act? So very well said. Very well said. Couple last thing, it is not acceptable in the Patient Safety Act for video cameras to substitute for nurses. So for example, if they have some sort of off-site thing as a safety valve, it's not acceptable to include that in the ratio, the standards. There's also, hospitals must use validative safe staffing plan tools for acuity. Again, there's no cutting, the people who stock the rooms, the environmental services, there's no cutting that to meet the standards. There's also a staffing review committee, which is appointed by either the collective bargaining, or if it's a non-union facility, this facility doesn't have a union, it would be the nurses that would be voting on that. And then there would be an orientation process too for nurses that get pulled, or if they're bringing in agency, to make sure that those nurses are trained to work on that floor. So you're not getting a nurse that is not trained for it. And I think this is the last one that we have. How would you respond? You're meeting with your safe senator to ask for support. And before you can say why you support the bill, the staff responds, I'm hearing that hospitals need to be able to adjust staffing with acuity. Having set ratios ties their hands to react in real time to patient needs. So what might you say to that legislator?
They're not acting now. Sorry, but that's true. They're not acting now. They are doing whatever they want to do now. And even without a pandemic, this is a safety net that we all need. And we adjust now to acuity, but they don't act in the best interest of the patient now. That's all.
Others?
I would actually have to ask him where he's getting his information from. Some hospitals, I don't think that they're doing it according to acuity at Fitz. I know when we're different, they close. We don't have Mercy Philly anymore, but when I worked there, it was Misericordia when I worked there. we went by acuity, and somehow they stopped doing that. So I don't even know how they do staffing, how the grids are made up. I mean, we have our grids, but then they staff. I don't even know how they come up with the numbers, but it's not always according to acuity.
They come
So
up with it with their budget, with their dollars.
exactly, and until they start merging a little bit of both, then the patient loses out. So, and that would be my response to him, that it's not about the acuity, it's about the patient. So
One thing I just want to say is that, I mean, as this presentation is going on, it's so clear that no matter what talking point they throw at you, and they're going to throw talking points at you because it's what they're hearing. And a lot of time it's their donors that are the hospital association that has a lot of money that they enjoy getting for their campaign donations, and they are being fed these talking points, responding just as you are with what you're actually seeing. It is an absolute truity that acuity is not being taken into account in many places at all. It is also good to know that the Patient Safety Act does actually reflect acuity, because these are not fixed ratios. They can actually they can actually make it more stringent if needed. So there is that that adjusting for acuity. But you're right, acuity isn't happening right now without staffing standards. So but I think these are great. So a lot of this is just being ready to respond to something that does not make sense at all, but they're very convinced that it is a good point. So just a couple of things just to close out. Legislative days are important to be active in. Contacting your representatives, joining professional organizations, taking advantage of speaking opportunities, writing op-eds and letters to the editor about safe staffing, being part of research, conducting research, canvassing for issues and candidates that are supporting us, letting them know, when they support us, and especially if they're in your district, that you're willing to go to bat for them because they're going to bat for us. And being active in your community. Consider becoming a committee person or running for the board, running for board positions. And also, what I think very important, running for political office, because if we had as many nurses as we did lawyers in the state legislature, we would be in a really good place right now. So one thing you may want to do, if in case you need a really quick find my state legislator, if you Google find my state legislator, you'll find them. Also, call the office of your state rep, your state senator, ask if they're supporting the Patient Safety Act. If they're supporting, thank them. Ask them, are you co-sponsoring? And you would really value that. And if they're not, tell them your story. Really put them on the spot, because we've been doing this for so long, fighting for safe staffing, and it is getting to the point where if you're saying that you listen to nurses, then that nurses are heroes, then you respect nurses, you have to actually listen to nurses, and you have to actually do what we say at least once. And this is something that we've united on. Nurses are united. All the nurses were saying the same thing: pass this bill. And so if they're telling you no, I would prepare to tell them your story. Any questions? I'm sorry, I didn't save that much time for questions. I apologize. But any questions on this Patient Safety Act or anything we discussed today?
You do have a question in the chat from Francine. Are procedural units and same-day surgery in this bill as far as ratios?
Yes, they are. They are. It's actually in the text of the bill. If you Google House Bill 106 or Senate Bill 240, you can pull the bill, and it's like the third of the way through the bill. But it's listed.
Good to know.
And these ratios are for every shift?
Yes, day
Okay.
shift, night shift, evening shift. They're all the same.
I think that things on 3 to 11, you have the same patients all day long, and
Yeah,
resources
exactly.
you go from 1 to 8.
Yeah, that was something that was not going to change, because the nurses are giving that feedback throughout this. Patients are not sleeping on night shift, right? They're not.
Patients are quiet, they're sleeping. Yeah, you haven't been in the hospital at night.
Mm-hmm.
Okay.
Mm-hmm.
All right.
Mm-hmm.
This was a really great session. I enjoyed you all. I enjoyed this feedback. Did you find it helpful?
Yes.
I would add one plug before we sign off about that calling your state rep or emailing or doing anything like that to reach out directly to elected officials. It just so happens I am on the school board in my local town, and I actually ran for state representative. But I mean, I could just tell you firsthand because of this that, and school boards may be a little bit different because it's a smaller entity, but nevertheless, those direct contacts from constituents make all the difference. They really do. They are counting, they are reading. So, I mean, it may not be the end of, obviously, as you get up the food chain, the busier folks, a state senator might not be able to have time to read every single email they receive, but somebody is. And they are counting them, and that information is being cut.
They're tallied.
Communicated. Yep, absolutely. So that's never a waste of time.
Thank you. So we're actually, thank you for sharing that, and thank you for sharing your comments and your feedback. So we're actually a minute over, so I'm going to stop sharing my screen. And Lydia, I guess that's a wrap, right?
That is a wrap, everybody. The PowerPoint presentation itself will be also shared if it will be shared later. If you want to, go under this session in the conference, you can look and you'll see the PowerPoint itself. So I'll share it there. And if you have any questions, I think your contact information is there too, Tarek. If yeah,
feel free to reach out.
Okay.
Thanks, everybody. Have a great night. Thank you.
Good night.
Night.
Good night.
Thank you. Good night.